I'd like to introduce our next speaker. This is Dr. Jorge Castillo. Oh. He's a very distinguished doctor from the Dana-Farber Institute, and he will tell us about the upfront treatment approaches.
Thank you.
This is how the...
Excellent. Thanks. All right. Hi, good afternoon. How are you guys doing? You guys look great. You've been working out? I can tell. So it's a pleasure for me to be here. For those of you who know me, because I see a bunch of familiar faces here, but for also the people who do not know me, my name is Jorge Castillo. I'm the hematologist oncologist, basically taking care of the clinic at the Dana-Farber Cancer Institute, big center for Waldenstroms. I've been taking care of the clinic for the last 3 years. I'm essentially the physician who sees all the patients, along with Tony, my nurse practitioner, that's right there on the back. You'll be hearing from her shortly. And between the two of us, we take care of approximately 1,600 people with Waldenstroms. We get to see 700 patients every year with Waldenstroms in our clinics. And when I got this job, my first concern was, am I going to be seeing just Waldenstroms for the rest of my life? And because previously to that, I was used to the variety. I was a blood cancer doctor, so I was seeing all the lymphomas and all the leukemias and all the myelomas, and there was a lot of variety. And there's a beauty on that. But then, 3 weeks, they told me you have 3 months to decide if this is what you want to do. And within 3 weeks, I made up my mind already. I mean, the cases are so interesting and everybody is so different. When you get to see so many patients, then you understand what is the difference between one patient and the next. And there's so much variety in there too, and so many questions that have not been answered that, that basically what fuels me every day to go and see patients and try to help the best I can, the best we can. So today, I'm going to be talking about frontline treatment for patients with Waldenstroms, and we'll go over this data the best we can, and obviously will be available for questions afterwards and during the session in the afternoon as well. These are my disclosures. I have a bad habit to actually just show you who gives me money and what for. All right. What can I say? We cannot talk about Waldenstroms without talking just a little bit about Waldenstroms. I mean, you have heard this name so many times during this, last 3-4 days. We have been hearing this last name. We have heard it probably like around 400 or 500 times. He was a very amazing physician, and one day he was being praised. I think it was in the United States that he was being praised of so wonderful contributions to science he had made. And he, very humbly, he said, I'm just a clinician. I just report what I see and describe it. But, I mean, that was extremely humble from his perspective. I mean, he has described Waldenstroms is one of the diseases that he actually described. Like, there are so many other diseases, immunodeficiencies, autoimmune hepatitis. So there's so many stuff that he has done. It's amazing. So, I'm also a clinician. When they offered me my job, they told me, how much laboratory time do you want to have? And I said, none. I want to see patients. I want to treat patients. I don't want to be pipetting tubes. I don't want to be doing bone marrow biopsies in rats. That's not what I want to be doing. I want to see patients. I want to give new medications. I want to see how the medications work on patients. So I really look at Dr. Waldenstroms, and basically he's like the epitome, or like the maximal point of what I would ever aspire to be. This is the disease that brings us here. And I still have patients and doctors who ask me the same questions. So is this a lymphoma? Is this a myeloma? Nobody really knows. It does have some features of lymphoma, has some features of myeloma. It's a little bit in between, I believe. But by the WHO classification, this is a lymphoma. And it falls into the category of lymphoplasmacytic lymphoma. Now, lymphoplasmacytic lymphoma, per se, could secrete IgM, IgG, IgA, free light chains, and some patients do not secrete any protein. 95% of the lymphocytic lymphomas, lymphoplasmacytic lymphomas, do secrete IgM. And those patients are the ones that are considered Waldenstroms, macroglobulinemia. As Dr. Voss said earlier, is the IgM, the macroglobulin that gives the name. So if you have a lymphoplasmacytic lymphoma and your lymphoma secretes IgG, then you do not have Waldenstroms macroglobulinemia. In the bone marrow, we will see that this disease is actually made of 3 different types of cells. When we talk about lymphoma, it's classically lymphocytes. And when we talk about myeloma, it's classically plasma cells. It's one type of cell. Here, in this disease, what we see is actually a group of B cells, a group of lymphoplasmacytic cells, and a group of plasma cells. 3 different types of cells, but all of those cells make up the same tumor. And we know that because we have done genomic analysis on those cells, looking for this MYD88 gene that I'm going to be talking about a little later. And those 3 cells groups have the same mutation. So they all belong to the same family. So it's 1 clone made of 3 clones. So you can understand how hard it is to actually kill plasma cells alone. And now when they have 3 groups of cells, it's obviously much, much harder. And this is how it is. I mean, it's a disease that essentially is in the bone marrow, and that's why we do bone marrow biopsies on patients to try to make a clear diagnosis. But in a proportion of those patients, it goes beyond the bone marrow, into the lymph nodes, into the liver, the spleen, and other organs as well. We have seen lymphoplasmacytic cells in some patients who have had prostate surgeries for prostate cancer, and there's some Waldenstroms cells in there. We have seen Waldenstroms cells in the spinal fluid surrounding the patient's brains. We have seen these lymphoplasmacytic cells in the pleural fluid in patients in the lungs. So these cells can pretty much go anywhere. Where a normal cell goes, these cells can also go. But they do not colonize sometimes. So most of the times it's in the marrow only, very much like myeloma. And some patients do have some lymph node involvement, very much like a lymphoma process. You have heard about all this already. I want to just summarize something. I just want to tell you that the most common symptom of a patient with Waldenstroms is actually no symptom at all. The large majority of the patients that come to see me are completely asymptomatic. Over 50% of the patients that come to see me in my clinic are asymptomatic. They were being worked up for other reasons. They either had a surgery that was coming up, and somebody ran a specific SPEP and they found an abnormal IgM spike, or a patient of mine who was just walking his dog and then his pinky got fractured and they did an MRI and the bone marrow looked a little weird and they say, oh no, you have something, and they send the patient for additional workup. Those patients are essentially asymptomatic. So I don't want you to feel or think that once the diagnosis is made and the patient should be treated, because we don't treat asymptomatic patients, and I'll try to make a case for that a little bit later. So, but in the patients who do have some type of symptoms, there's a variety of different symptoms and signs that patients can present with. The most common one is anemia. Anemia, I would say, is probably the reason to treat a patient with Waldenstroms in about 75% of the times. So it's probably by far one of the most common ones. Now, anemia has 3 different ways of presenting, and this is when things get a little hairy. On one side, you could say, well, there's so much bone marrow disease that the good bone marrow cannot produce red cells anymore, and that's the most common reason. But we do have patients who have iron deficiency anemia because these cells do produce hepcidin that blocks the absorption of iron into your blood. And you could be iron deficient, and you could be anemic because of iron deficiency and not precisely because of bone marrow overcrowding. The third one could be cold agglutinemia, as we heard from Dr. Vos. Those are antibodies that basically coat the red cells, and our immune system destroys them. And patients can be anemic because of that too. So there are 3 reasons why patients with Waldenstroms can be anemic. But sometimes other patients can present with low platelets, low white blood cells. You already heard everything about hyperviscosity. We just completed a study that is going to be published shortly, in which we basically separated our patients in groups of 1,000 IgM, or I don't know, to 10, I guess, in your unit system. So 0 to 1, or 1 to 2, 3, 4, 5, or 0 to 10, 20, 30, or in 0 to 1,000, 2,000, 3,000, 4,000, 5,000, 6,000. And we basically analyzed what is the incidence of hyperviscosity depending on the IgM level. And we saw that pretty much nobody with IgMs below 3,000, or in your case will be probably 30, presented with any hyperviscosity ever. Between 3 and 6,000, between 30 and 60, then the risk of hyperviscosity is higher, significantly much higher, but not dramatically much higher. But over 6,000 is when we really saw the taking off. The risk was just so high that in our minds, we don't have to, or we shouldn't wait until patient is symptomatic with hyperviscosity, being so life-threatening and so dangerous as it is, as you heard from Dr. Voss. So we would like to maybe take it a step before and say, well, your risk is very high already. You are not symptomatic yet, but do you really want to be symptomatic for something like hyperviscosity? So we are trying to, investigate deeper on this and see, kind of validate it in other groups. But we are going to start using around 6,000 for somebody who's asymptomatic to start recommending treatment in those scenarios. We have also heard about the adenopathy splenomegaly. If you look very carefully throughout their lifetime, patients with Waldenstroms will become more and more, will have more and more lymphadenopathy and splenomegaly. But those are rarely symptomatic. Rarely symptomatic. Those are lymph nodes that do not hurt. The spleen and the liver do not hurt. If they do become so large to the point that it's actually giving you pain or discomfort, or they don't just look nice and you want to look a little bit better. So those are reasons sometimes what we need to treat. But the fact that you just have a lymph node alone and otherwise you feel well should not be a reason to treat. That's the lymph nodes. Those are swelling of the lymph nodes. Yeah. No problem. So, and then we have other more rare scenarios like cryoglobulinemia. And again, as Dr. Voss mentioned, I mean, if we, and I do check cryoglobulins in all my patients, I would say probably about 5 or 6% of my patients do have cryoglobulins. But in the large majority, I would say over 90% of those patients is not symptomatic. They do have it, we know they have it, but we're not doing anything about that. If it becomes symptomatic, we'll do something about that. And similar with cold agglutinemia. If I run cold agglutinins in all my patients, and about 5% of patients do have it, but over 90% of the patients are asymptomatic from it. So if they're asymptomatic, it's good to know that you have it, but we're not going to do anything about that. But we'll be ready in case that becomes an issue down the road. So these are the accepted criteria to begin treatment in patients with Waldenstroms. Now, it's sometimes a hard sell when patients come to my clinic and I tell them, yeah, you have a blood cancer and it's incurable, and I'm going to do anything about that. I'm going to just watch you. Doesn't make any sense in some patients' heads. It doesn't. It's a hard sell. I would understand it too. But if one understands that this is incurable despite the strongest chemotherapy we can give you, and we have tried, it's not that we have not tried. Patients with Waldenstroms have received autologous transplants, allogeneic transplants, high-dose chemotherapy. We have not been able to cure a patient with Waldenstroms in the last 70 years. So do I really need to continue giving you high-dose chemotherapy for a non-curative purpose? Probably not. On the second hand, patients with Waldenstroms are living longer. And if you look at the different population-based analysis from different countries, you will see that the survival of patients with Waldenstroms is over a decade. That's the average. That's the average, having in mind that the average patient with Waldenstroms presents on their early 70s. So younger patients tend to live longer, and older patients tend to live less, and that's understandable. So I cannot tell you that your life expectancy will be the same as somebody of your same age without the disease. I cannot tell you that. But it's not a death sentence. It's not like, doctor, I'm going to just live for 5 years, so what's the point? That is not the issue. We have patients who have lived for a long time with this disease. We have patients in our clinic, 2 decades, 25 years. I just met somebody 2 months ago, 33 years with the disease. So the patients are living longer. You are getting stronger. You're getting smarter. We're trying to help you. So if we know and we acknowledge that you're going to live for a long time, we need to be very strategic about when and how to give treatment. So we shouldn't be in the business of giving chemotherapy to patients just because you were diagnosed with a blood cancer, but rather understand, when this disease is affecting your quality of life and how you function, and then treat at that moment, and treat with something that is effective, that is not too toxic, so we can balance, The ideal treatment will be, I'll cure you with no side effects. That would be the ideal treatment, but that doesn't exist. So we need to choose very personalized treatments based on what you think is the best for you, your physical characteristics, your comorbidities, your other diseases, what symptoms you're having. So it's so, and now your genomics, now your mutations. So there's so much information that we need to put together, you know, and this is an exercise that we do on a daily basis. Patients come, you don't need to be treated. You need to be treated. Then let's study your case, understand your case, so we can recommend the best treatment possible. All right? Yes?
I'm missing the level of IgM in this guideline.
Well, it says, yes. So level of IgM is not a criteria. We are trying to make it a criteria. Good. Oh, no problem. So we have hemoglobin less than 10, but hemoglobin of 9 is not really a life-threatening situation. So if you have a hemoglobin of 9.5 and you feel fantastic, I wouldn't treat you either. Platelets below 100, same thing. If you are feeling well with platelets of 80,000, that should not be a reason to treat because it's not a life-threatening situation. Hyperviscosity is life-threatening. That's a different story. Me, myself, I will tell you, you know what, you need to be treated. Let's go on plasmapheresis and let's treat you right now. Neuropathy has to be moderate or severe. Mild neuropathies sometimes can go on for decades without changing. So mild neuropathy should not be a reason to treat. Symptomatic lymphadenopathy, hyperosplenomegaly, all these other complications we talked about, cryoglobulins, cold agglutinins, and extramedullary disease, kidney, lungs, brain, things like that. Because we don't know if those are going to come back after you treat the patients. You don't know if the kidney is going to come back. You don't know if the brain is going to recover from the attack that is suffering from the disease. So in those scenarios, we tend to be a little bit more aggressive. So you can imagine these are guidelines, these are criteria, these are not Godspell. But we try to use it so we can make good decisions. And if we believe there's something that is, you know, manageable, then we manage it. And if something is unmanageable, then we treat. Let's talk about the options. And I want to start with the first option, which is rituximab single agents. We have been using rituximab for lymphomas since the 1990s. And Dr. Trion has been one of the first people who actually started using this in Waldenstroms. It's an antibody directed against CD20. All your B cells in your body, normal and abnormal, Waldenstroms included as in abnormal cells, do have this marker in the membranes. So this is an antibody that goes and looks for that CD20 marker, coats the cell, activates the immune system. So the immune system actually kills the malignant cell. The antibody itself can also do something inside the cell and kills the cell by itself. But there are at least 2 or 3 separate mechanisms by which rituximab works to try to kill the malignant cells. Accumulates in the body. Rituximab will not be the medication that you will pee out on your urine or your liver will metabolize. It will stay on your blood. And the only cells that can metabolize your rituximab are your own white cells. So if you can imagine that the only cell that can clear the rituximab are the cells that are being killed by it, then it's very easy to understand how it can accumulate on your body. So people can get 4 weekly doses of rituximab, and they can have rituximab circulating in their systems for about 6 to 9 months, just to give you an idea. Now, this is the first study in 2001. 30 people, retrospective. This was not a prospective study. People receive anywhere between 1 and 11 infusions. And the IgM, there was a response. This is the average. IgM went from 2,400 to 1,500. Bone marrow involvement went from 60% to 15%. So those are response. That's a response based on our criteria for response treatments. 60% of people actually responded to this regimen. I think it was the first time a regimen was used that didn't contain any chemotherapy whatsoever. So see a response without chemotherapy was just something. These are additional studies that came out afterwards. This is a Greek study, 17 people. This was prospective, meaning patients were enrolled and they were followed prospectively. 4 weekly doses and then repeated 3 months. This is what Dr. Trion did posteriorly as well in the United States. Very similar response rates, anywhere between 40 and 60%. And the responses were, 3 months to respond, to initial response, and to the best response was 1.5 years. So the peak of the response is not going to be seen rapidly with rituximab. And you need to understand that, right? Because you're saying, within 3 months I'm not responding to it. That's not appropriate, right? You need to wait and see until you get a deeper response as well. But it took about 1.5 years for patients to start progressing after this treatment. So it did something good. It's better, people that felt that it was a good thing not to be getting chemotherapy, but it's also a little bit short-lived. These are the adverse events. Any lecture that you're going to see from me, at least, I'm going to try to be very balanced. I'm going to give you the good things and the bad things. because that's the only way to make the right decision. So we can have the infusion reactions secondary to rituximab, and if anybody here has received rituximab, probably you have reacted at some point with this, right? The chills, right? Exactly. So there's an increased risk of infections, there's low blood counts, and hepatitis B reactivation. Now, additionally to that, these are something that pretty much anybody who gets exposed to rituximab experiences. These ones on the right side are more specific for Waldenstroms. And only if you see a large number of patients, you can actually see this. You know, because I have shared this with other colleagues who see just a few patients with Waldenstroms in their lifetime, and they told me, I don't see those problems. It's like, well, you don't see enough patients, unfortunately. Number one, the delayed responses. We already talked about that, you know, about a year and a half to see the best response to rituximab. The IgM flare, about 40% of patients will have an increase on their IgM after rituximab is being given. That increase in IgM is not progression of disease. It is real IgM. It's not fake IgM. It's real IgM, so you can have hyperviscosity issues and things like that, but it doesn't reflect what's happening in the bone marrow. The bone marrow is responding, but your IgM is flaring. So we need to be, you know, careful about that. And then intolerance. If you reacted the first time, that's okay. But if you continue reacting the second, third, fourth, and it's getting worse to the point that you ended up in an intensive care unit or something of that nature, those are patients who should not get more rituximab. They are developing these allergies to it that is not a good thing to continue. So about 7%, which is not a lot, but it's real. 7% of patients with Waldenstroms will become intolerant to rituximab at some point. And it could be within few cycles, could be during several years of treatments. It is a little unclear what motivates this, but it happens. And we can use a second antibody called ofatumumab that in about 3/4 of patients do well. The other quarter will be also intolerant to ofatumumab. So switching is not a guarantee that you will not be intolerant to the next regimen. This is a study that just got published by a colleague of mine and Dr. Olszewski. It's a very complicated, but I'll make it very simple to you. Look at the bars, the black bars. Yeah? That's single-agent rituximab. And this is how patients are being treated in the United States right now. 1994 on the left, the 2000s in the middle, 2010s on the right hand. 50% of patients or more in the United States are being treated only with single-agent rituximab. So when we are here in the panel, during the discussions, we're talking about combinations and the new medications and things like that, but this is what is happening in the real world. And I wouldn't be surprised if a very similar picture is also in Europe, in which patients are treated with single-agent rituximab too. It's a good thing, it's a bad thing, we need to figure that out. There's another agent, a little older, called cyclophosphamide, which is a formal chemotherapeutic agent. It's called an alkylating agent. There are 2 studies that were done, a Greek study and a German study. And in both scenarios, it was chemotherapy. So patients lose their hair, they were vomiting, they were nauseated, they had blood counts dropping, infections, which is the typical side effects associated with this. But look at the response rates, 83%, 94%. So really great response rates, if you think about that. Really good response rates. You know, in the 3 years before the patients progressed again. You know, about 5 years before patients progressed again. So now we're seeing deeper responses, longer time until the patients develop the next round of disease, symptomatic disease. But as I said before, I mean, these are the side effects, you know. And I want to bring your attention to this one here. Any chemotherapeutic agent will have a very small risk. It's a very small risk of having a secondary leukemia. Some chemotherapies are higher, some chemotherapies are lower, but about 1%. And I mean, can you be that 1%? Of course, you can always be the 1%, right? Odds are 99 to 1 that you will not have a problem, but there's a small chance that it could be a problem. And that's something to have in mind when we want to go for chemotherapy. The newer non-chemotherapeutic approaches are called proteasome inhibitors. And Velcade belongs to this, bortezomib, carfilzomib belongs to this group of drugs as well. So it's a different mechanism of action. It's a very smart mechanism of action if you think about it. So you imagine your malignant cells are full of protein inside, right? A lot of protein. So they need to recycle that protein to be able to survive. So one of the recycling mechanisms the cell has is called the proteasome. So basically you give a medication, that blocks the proteasome, so the cell all of a sudden cannot get rid of that protein that it has in the cytoplasm. It's kind of, the trash accumulates on your house to the point that you cannot get rid of it. And then the cell just has to die. It cannot sustain. It reaches a critical point in which it's not sustainable anymore, and the cells die because of that reason. So it is a different mechanism that chemotherapy. Chemotherapy goes inside your cells, in the genes, causes mutations in the good and the bad ones. And then you can have all these other problems. This one also goes in all the cells, good and bad. But the normal cells have other ways to recycle their trash. They don't depend almost exclusively on the proteasome. The malignant cells do depend almost exclusively on that. And that's why they die, and the good cells do not. And obviously there's no concerns with secondary malignancies with these agents, but it has other problems, as we will see. So good responses, about 70%. This is when it's used alone. This is a study from Canada. Used alone, very, very highly efficacious. When it's used in combination, and we have a study from our group and a study from the Greek group here, we can see that again, response rates, 85%, 96%, really, really great, fantastic response rates, very deep responses. 5-year survival, 4-year survival before progression. I'm not saying overall survival, this is progression survival. So deep responses, long progression-free survival, this is a great option too. But it doesn't come with a price. It doesn't come without a price, Peripheral neuropathy, this is a big problem. When it's given intravenously twice a week, patients can have bad neuropathy. 60% of patients had to stop treatment before it's time because of neuropathy. But now we're using it subcutaneous. And now instead of giving it twice a week, we're giving it weekly. So those patients are having less neuropathy, so it's becoming more manageable. It can also give you low platelet counts. Patients need to be on steroids for these medications to work better, so some patients are more sensitive to steroids than others. And most of patients need to be on zoster prophylaxis, shingles prophylaxis, and that's throughout the treatment. So those are things that we need to think about. Diabetics, they might have a problem with this. If you already had episodes of shingles or recurrent shingles, you need to be concerned about that. So if you're a pianist, you really don't want any neuropathy, right? So again, we have to be very careful about the profile of the patients that we treat. This is a second generation. It's not available in many places in Europe, but in the United States we do have it. It's called Velcade. It's a second generation proteasome inhibitor. It's intravenous. It can be given weekly or twice weekly, highly effective as well. This one doesn't give you any neuropathy, which is a good thing. But again, on the other hand, increases your glucose, increases your cholesterol, can give you other problems too. Nothing is free in this life. And it can give you some problems with cardiomyopathy too. One patient had a bad cardiac problem. Was it the disease? Was it the medication? It's hard to say. And again, the same issue with steroids and shingles prophylaxis. Let's move on to a different agent. This is an agent that comes to us from Germany. It's a fantastic agent. In Germany, they use it for everything. In the United States, has only been approved for lymphoma so far, but in Germany, they use it for lymphoma, myeloma, breast cancer, and so many other applications. So in this very small study, they compared benda-rituximab with R-CHOP, which is one of the chemotherapeutic agents that I was mentioning earlier. And benda-rituximab looked to be better, but this is a very tiny study. So I want you to be very careful with that. Excellent responses, 80% response rate, about 5 years before patients relapsed. So really, really good numbers as well. Really good for patients with the lymphoma form of the disease, lymph nodes, liver, spleen, pleural effusions. It works really, really well on those patients. But again, it's a chemotherapeutic agent, so it might affect your stem cells. If you're a candidate for a transplant, it might affect your stem cells. The Germans say that it doesn't. The Americans suspect that it does, so nobody really knows. Low blood counts, infusion reactions, very, very tiny risk of a secondary leukemia. Actually, probably the lowest from all the chemotherapies that we have seen, but definitely a good option to be treated frontline as well. And something that we have been advocating is maintenance. Patients get treated with whatever rituximab-containing regimen it is, and then should the patients be on maintenance or not? And really, there's not a lot of data on that. There's one study, and that's why I am not biased. This is a study from our group. It's a retrospective study, so with all the caveats and weaknesses that a retrospective study can have, we can show here that the progression-free survival is actually longer if you take the maintenance than if you don't take the maintenance. Now, in other lymphomas, maintenance have shown to prolong progression-free survival as well. Before it takes longer for the disease to come back when the patients get into some type of maintenance. But if you go to the Mayo Clinic, for example, they will tell you, yeah, maybe that's the case, but then you really need to do that, all the side effects that are associated with that, all the costs associated with that. So typically, the Mayo Clinic does not recommend maintenance. And I don't want to tell you that they are wrong. They're not wrong. Those are options that we need to talk and discuss about. And again, the same issues, infusion reactions, infections, and obviously dropping of the IgG and IgA, which sometimes in some patients, they need to be replaced with IVIG to prevent further infections. But things are changing now. We're living in a new era. And this is research that has come out from our center, from the laboratory aspects of our center. It's a specific mutation in this gene called MYD88. It results that about 90% of patients with Waldenstroms would carry this gene. And it doesn't matter if you are from the United States, Europe, China, Japan, India. The mutation is always there in the same spot in all the patients. Well, not the patients that have it, because we have a group of people who do not have it. And this is just an amazing, validation. So we said, now we have a mutation that is characteristics of our patients. And can we do anything about that? Can that help us treat patients better or different? So Dr. Wang Yang, who was here, but maybe he's here still, he basically started to study this mutation and how the mutation signals and what does it do, and how can we treat patients better based on that. And he found a specific target here, BTK, that will be targeted with an agent, and you will hear about that in the next lecture as well. But just to give you an idea of all the different potential targets that can be coming down the road, because all these steps in these pathways are potentially targetable. The MYD88 binding can be targeted, IRAK1, IRAK4 can be targeted, all these other agents can be targeted at some point. PI3 kinase can be targeted, BTK can be targeted. So all these discoveries or new pathways are also potentially targets to treatment. So I think these are the initial discoveries, but more discoveries are coming down the road. So this medication, this mutation, I don't know, I think the Dutch part is a little messed up. But here, there's Dr. Hunter, who was earlier here. He actually did additional genomic testing looking for this mutation, and he found this mutation called CXCR4 mutation that also, is present in about 40% of patients with Waldenstroms. So can we use this in the future to treat patients? Would those patients be treated differently than the patients who do not have the CXCR4 mutation? So all this is just, areas of new research coming down the road. So just to summarize, and I don't know, okay, perfect. Just to summarize here, in this table, we can see here that, all the different agents that we have mentioned so far, and all the different response rates that we have seen in those patients. The major response rates, meaning more than 50% decrease on the IgM, how quickly they respond, and how long it takes for those patients to progress. And we see that we're getting to better numbers and better numbers with newer treatments. So the future looks very promising, because we just completed a study that is on the left. We showed some data here with a new proteasome inhibitor called ixazomib. It's a pill Velcade, or it's a bortezomib in pill form. But being a pill form, it doesn't give you the neuropathy that Velcade does. So we have completed a study, 26 patients out of 26, and the data that I presented on this panel was data from the first 20 patients who have completed the 6 cycles of induction. So it's very preliminary, but already showing an 80% response rate, 80% at the 6-month mark, and a major response rate of about 50%. I can only expect that these numbers are going to get bigger with time, because we're just at the 6-month mark. The whole treatment plan is a year and a half of treatment. So it's very, very early promising data. And there's a medication called ibrutinib that you will hear later, but we are trying ibrutinib in the frontline study too. We have about 18 out of 30 patients already enrolled. We have 12 spots left. And we're doing whole genome sequencing in all the patients on a yearly basis to understand how the disease changes when it's exposed to this agent. And we are including all patients with all mutations to understand really a little bit better how these mutations affect the medication as well. As I promised you, we are discovering new pathways. And as we are discovering new pathways, we are discovering new targets. And as we are going for new targets, we already have medications that target those pathways. So it's a matter of time. My plea to you and to any patient that you know is to participate in a clinical trial, because that's the only way to really find out if these medications that have not been given to patients with Waldenstroms yet are really better of what we already have. And if we don't participate in clinical trials, then we'll never find out. All right? So just a very limited list of what is coming in the future. We have already a clinical trial running on venetoclax in patients previously treated, and we have a clinical trial plan on daratumumab, another one in ulocuplimab, and our laboratory is working very hardly on getting IRAK1 and 4 inhibitors, as well as MYD88 assembly inhibitors. Those are going to be hitting clinical trials in the next couple of years from our center. And we're going to have collaborators everywhere in the United States and outside, probably. So promising future for patients with Waldenstroms. Finally, multiple treatment options. And as you can imagine, we cannot decide very simply. It's not a menu. Patients don't come to see me and I give them a menu of the different treatments, and they say, okay, this one is for you. We need to analyze the patient, understand really well what the morbidities are, so we can actually personalize the recommendation. Rituximab can be used as single agent. I don't think that's a wrong approach, but we prefer to combine it to get deeper responses and longer responses, as you have seen. Bendamustine, bortezomib, carfilzomib, cyclophosphamide in combination with rituximab are very effective. We understand very well how they work, and we can manage them appropriately. Clinical trials are very exciting, and they are coming up with newer mechanism of actions, never before seen. And I think the future treatments will be less toxic and will be more effective on making patients feel better. Thank you for your time.